Pranav, welcome, Nicola and the team. This is the fifth in our public accountability meetings with health boards. Obviously, you've got the Welsh Government team here. You've got representatives from your board. There are a number of us here, but I suggest that rather than go around the table, that each of us introduces themselves when we speak for the first time, in the interest of time. The meeting's being live streamed, as you can see. The public can view the meeting. There'll be a recording of the meeting available on the Welsh Government website for the public after the meeting, and people can speak in Welsh or English as they prefer, because there's translation both in the room and online. We've received, thank you, the detailed evidence pack from the board. We have an agenda which covers the finance and planning position, access to services, developing services for the future, and strengthening how the NHS is run and how the board is run in this discussion. The evidence pack covers those areas, and so there has been some assurance from what you already provided. So the meeting therefore will focus on those areas where we're looking for further assurance from you. And a number of the questions which we will ask and the points which we will discuss are motivated by correspondence, which we and you no doubt have received from the public. At the start of each of the four blocks that we discussed together, it will be very helpful if somebody from the board could give what I hope will be a very brief introduction to the board's perspective on those areas. I'm hoping that we can keep those to about 4 minutes each, and I'll give an indication if that's straying too far beyond there, because I'm keen that we have enough time for there to be a proper discussion of those areas. Before we get into the agenda, Anne, would you like an opportunity to make some opening remarks?
Thank you very much, Cabinet Secretary, and we really welcome the opportunity to be held to account and to show what our aspirations are, to be perfectly honest about the concerns that we have and what we're doing about it, and also to enable us to outline our plans for the future, particularly improving health and well-being. We have just published our new strategy, Gwent 35, which looks very much at better health and care and much better lives for the population. So we aim to get everybody to same health status by 35, which, as you can imagine, is a tremendous uphill job. We feel we've made great progress on the development of our community services. Each of them are slightly different because they've largely been designed by the staff who work and live in that area, and therefore reflect the needs and the desires of the population, which we felt would work better. And that certainly seems to be the case. We are redoubling our efforts in respect of secondary care to ensure that they are as effective as possible and that the quality of those services are really maintained and, where necessary, improved immediately. Demand has been inexorable. It's been very difficult, but the staff have coped extremely well. I know they say, oh my goodness, it's the pressure, but they have responded very professionally, very, very well. So we're constantly reviewing the cost effectiveness of our services, and we've been helped by your performance and improvement team. They have given us some very good advice, which has been quite consoling to us, which is handy. And we are very, very mindful of the use of resources, which no doubt we'll come back to, both in financial and workforce terms. So our services we want to see as totally productive, forward-looking, and bringing a benefit to the population, and to be designed so that they actually reflect what those needs are, and we can do that well. Obviously, as you know, we are cooperating with others in order to achieve this, and we are making progress in South East Wales. But all this has got to be underpinned by really, really effective preventative action, and that is a huge challenge for us in some of our areas. I feel that the board is now quite a settled one. We've had quite a few changes, but it's good quality, and I think we've got a really good team in order to help us push this forward and to achieve our ambitions for our population.
Okay, great. And the number of things in there which we'll obviously come on to discuss in the next couple of hours together. So let's start on the substantive agenda. So First agenda item relates to finance, planning and escalation. Obviously the board is in escalation in relation to finance and planning. So who from the team would like to give us an introduction on that?
Okay. Obviously, we were, in terms of finance, ambitious to be able to break even. We knew we were taking big risks of possibly difficult to make savings of 40 million, but actually we've exceeded that. However, demand and some other problems which we'll come to have prevented us from doing that. We did identify a £25 million risk at the beginning of the year, which we did discuss with Welsh Government. But we bettered the savings, but we are still going to overspend by 19.9 million. As you asked me 3 or 4 weeks ago, we have been developing a plan to try and bring that down even further, and we do have some proposals to refer to. And we think that that with increased demand, we should be aiming to come up with a plan for next year that will improve further. We have saved about £111 million over the last 3 years, which is no mean feat. We will have to look at service reconfiguration again. We'll have to look at unfunded elective care and to disinvest in some of our services that aren't adding value. We take productivity and cost effectiveness very seriously indeed, and we indeed are the second lowest spend per head of population in Wales. But nevertheless, we have got to go further, and we've got to ensure that we can maintain our services within the budget allocated. So we are developing a further 3-year map to have financial sustainability, strengthen performance and accountability, and strengthen our BFF.
Okay. As you say, the board submitted a balance plan at the start of the year, and its ability to do that was one of the factors taken into account in the de-escalation. So the fact the board is failing to deliver that plan is very serious in its own terms and in the context of that as well.
Yeah.
I want to know from the board whether you would say that was down to inadequate planning, or is that down to a failure to deliver? What's your analysis of why that's gone so badly awry?
I don't think it was down to inadequate planning. I think that we've had some unexpected pressures on the budgets. Demand has certainly been very, very difficult to manage. And there are some unexpected developments that have come in, like the prescribing costs shooting through the roof, which is out of our control, and the CHC costs. And that really, again, is driven by demand. But I don't know, Nicola.
Yeah, no, thank you. And it's something we've reflected on quite a lot. So when we were making an assessment of whether or not we could put in a balanced plan, because I know at the February point we weren't in that position, we had a forecast deficit, but we've made such great progress. We felt it was right that the ambition of the organisation should be get to that break-even position. We did identify risks, as Anne said, up to £25 million. A chunk of that was around whether or not we could deliver another £40 million worth of savings. That was an element of the risk. In addition, we didn't really have headroom for any of our unseen cost pressures, or our forecasts went up. We did at one point, probably about month 3-4, we were about 40 million going adrift, which was a serious concern, because but we worked really hard and have got those £40 million savings now identified. So our savings risk was reduced and removed. So all of the 19.9 now relate to pressures that have either emerged or the growth has been higher than predicted, and Rob can take us through some of those in detail. So there are some areas where growth has gone, so there weren't new issues, but the level of growth that we were expecting was higher than we thought, particularly drugs and CHC. There were some funding issues we assumed which didn't come to fruition, and a lot of it is very much related to pressures on the ground that we've been experiencing around urgent care, diagnostic growth, cancer growth, and in areas such as mental health, where by stopping expenditure we felt we could compromise safety and delivery of some of those key priorities. So there weren't many new issues that emerged. We had £1 million in for investment, which we've shown we haven't spent really. There's been no investments made because we recognise the financial position we're in. It's very much been driven by operational issues, but talk and give a bit more detail if that would be helpful, but I just don't think we feel that there were issues that we're aware of that were in this.
Okay, so the board finalised its savings plan at month 5. Thanks, Dennis.
We'd identified around 25 of the 40 million in the plan, with 14 to 15 million unallocated. By the end of month 5, we had pinned down all of those 40 million savings.
So do you think that if the board had managed to do that sooner in the year, recognising the point you made that there were risks which you were aware of at the start of the year, that you would not be in the same position now?
I think if, I don't think that the extra time would perhaps give us more time to look at what our options are to make further savings, but I don't think
that sooner in the year you identify the savings, then bring it back they have, because there's more.
Potentially would have had a greater full year effect, yeah.
Okay, so how the board finalise that sooner, then you think position might be better?
I think if we'd identified some of the savings sooner, I'm open to some of our savings are non-recurrent. We've taken decisions to stop, maybe stop, not fill vacancies, not allow spending to go ahead the plan. So it's only when we realised we had these new operational pressures, we've taken some non-recurrent decisions, which an earlier position wouldn't have made any difference really.
Okay, I'd be keen to hear a little bit more about why the demand was unexpected. Are you the best place?
So in terms of our plan, for this year, particularly around some of the savings areas, I'm picking up on your point around if we'd have done, if we'd had a clear plan earlier, then clear effect would potentially have had a great benefit. So we did expect in our savings to look at rationalising our bed base. Demand and acuity has sort of overcome that in the year. We've been seeing improved levels since we originally had our deficit position, like start from 22 to 23 through the last 3 years. We were hoping this year would be a year of full recovery. Acuity continues to be a pressure for us. Bed blocking continues to be a pressure for us. So our opportunities to reduce costs through reductions of beds, we take 70 out, which is a couple of boards, but the opportunity to go further, which was the aim for this year, hasn't really come to light. In terms of the drugs pressures, some of those costs were.
Can I stop you there? Why has it not come to light? Prescribing is not coming to light.
Because we've had to retain bed capacity to deal with the pressures of the demands, yes. So our ED, our triage scores has increased. So we've got some evidence to prove the acuity is driving that. Our step down counts in terms of the ability to downgrade patients and move them through our system hasn't allowed us to free up beds to operationally reduce our bed base to the level that we've intended to. So that actually forms part of our future look in terms of the opportunities going forward and what we can do through service redesign and service changes to try and facilitate that for the longer term sustainability. In terms of other cost pressures, so our medicines costs have increased by about 2.5% to 3%, most significantly in the acute sector. And a lot of the business intelligence around that we were casting our plan didn't forecast those step changes, particularly around haematology and cardiology. It's been nice pronouncements plus additional work coming through. So we're seeing the costs of that and the demand of that and the new drugs being prescribed driving step change. Did also have some prescribing costs come through at the end of the year, which weren't forecast. And some of that is due to the fact that we get our final prescribing costs 2 months after the year end. So we wouldn't have forecast that level of spend. So that's £1 million driving 19 million that's reported as part of our deficit. And then, sorry. And then in terms of CHC, we've seen an 11% increase from last year to this year in terms of our cost base. We are still making savings in some of these areas, but the overall net impact is driving a cost pressure beyond what our estimates were. And we would have seen bigger savings and a lower cost shift in previous years. This year, again, it's just been higher than we expected in terms of the estimates. And we're cognizant of our assumption, testing our assumptions at the IMTP with peer health boards, and they're driving the key points, if you like. Locally, then, there's something to be recognised around our local acuity, our enhanced care demands, particularly on mental health. mental health is an area that we had some challenges with, felt we needed to invest for safety and to improve the quality of the offering.
And all of this was unexpected. That's the thrust I'm getting. I mean, that sounds very challenging in a £2 billion organisation. Effectively, that all of these things are the way you're describing them unanticipated.
I think it is in the context of, you say, 2 billion, so 1% move off target. Savings plan, so it was ambitious. We've gone just beyond that. We're at, in excess of 42 million, which in itself is a positive. However, the costs beyond what we felt we could reasonably assume to cover through our planning have emerged during the year. As Nicola mentioned, we have obviously kept a close eye on this throughout the year. Q1 review started to emerge these risks. Huge effort was put across the organisation to test the risks, test the forecasts, identify firm savings, picking up your point earlier. And we really did sort of push and challenge internally to get to the position that we unfortunately had at the report and following that review.
Okay, I'm bringing Jacqueline and then Howell.
So I want to just pick up on the potential for improvement, modernisation of pathways and how we keep people at home. So thank you for mentioning community and the work you're doing with it. I suppose my question then is, how much are they working with you and with GPs and consultants to keep those patients that are probably coming in with higher comorbidities and long-term conditions at home? So that bit about, how have you managed to turbocharge community in terms of keeping people at home more? Because that actually will help your frailty. So I'll just go through the bits I've got. So I just want to work through the pathway. I think last time I spoke to you, Nick, as well, you told me you did have a frailty SDEC of some description. And what I really understand is, if that's in post, do you know how many patients actually you're managing to turn back home? Because on average we see about 50% of patients being turned back home. So what are you managing to see to try and keep people with failed conditions out? And then thirdly, the percentage of hospital delays, because we often focus on pathways of care rather than actually the things that we have a bit more control about, which is actually the things that are stopping us discharging patients that are down to us, like waiting for a test, which is often the one. And then just circling back to the CHC costs. We know that in Wales that we have a longer length of stay than our peers across the UK. So have you seen a longer length of stay that's then actually meaning that actually we are keeping people in hospital longer, then that will then impact on CHC? So that whilst I'm trying to take you through the pathway of how we might reduce the degree of increase you have seen and try and keep people at home or get them out quicker before we know older people deteriorate in hospital, and we often we can't get them home where we'd like to get them home. I'm just trying to work through what you've really noted on in terms of modernising, improving your pathway through the hospital and in the community to try and manage exactly the scenario.
Can I just pick up the frailty issue in terms of community? As I said, the schemes are all different, but they're all being evaluated. And certainly the latest of them is the frailty scheme in the Chepstow area, the South Monmouthshire area, devised between the consultant frailty guys and the GP leader of what we call the neighbourhood care network, to maintain people in their own neighbourhoods. To maintain people in their own homes. So he and his team will undertake the home, keep people at home as long as possible. They need to have an inpatient stay for a particular reason. Then he into Chepstow to go out, and it's run like that. And he's recently reviewed the success of that, and he has kept hundreds basically in their own home. So they like it as well, and there is a high level.
I suppose the bit is if that's working there, where do you learn in the other bits of your community? And if you have, whether in doing that you've mapped through where some of your higher intensity patients are coming from that might not map to the Chepstow area.
We've done
Yeah, so just I think it was a lovely idea as Angela, having 5 local authorities obviously is a challenge for us because we're all slightly different. But there was a section 33 that we put in place many years ago, which is the Gwent Community Service, which is a proactive CRT service that is work for us to do, I think, in terms of evaluating that and whether we can put enough resource into there and whether there's more we can do. We have some really interesting discussions with some of the local authorities about how we do a step change around reablement going into next year. So there is definitely more work to do in this space. But I'll bring Jen in a second on some of this. In terms of we put an acute frailty team funded through the Regional Partnership Board last year into the front door at the Grange. So those who maybe, because of the capacity in the CRTs, end up coming to the hospital, how can we turn those around? And we also had a CAP team, which is the kind of community therapy team. We recently co-located those into what was our old discharge lounge at Grange, so that we kind of streaming these patients into this area, and many of those are being turned around. I haven't got the exact stats with me, but can get those. So we are seeing an impact of that. It's only been in place in this co-located space around 6 weeks. But we definitely, but it is about how do we get out early enough so they don't even end up coming to hospital. And then the issue around our hospital delays and the things we can do. I know Jen is working closely with the local authorities and within our own teams around how on part of the discharge work and the work coming up around the BIP fortnight again is going to have. That's been a relentless focus, and we can come on later to the focus we've seen around delayed discharges here. But our own hospital delays, we know there's some big cultural issues we still need to work through. I don't know if Jen, you want to pick up any of those?
Well, on this part, I want to come back to talk about the Grange more fully in the
Yeah.
next section. So perhaps we can keep that until then. Because
Yeah.
Great, thank you. Do you want to come
Yeah, a couple of comments if I may from my perspective of what's been presented and then one question. So I think we recognise the risk of the plan at the start of the year. Our assessment is a manageable tolerable level of risk. So we talk about a savings gap of 14 million. But from our perspective, it's pretty small in the context of a 1.9 billion organisation. The organisation's history of delivering and developing in-year savings plans, and I think that's been validated by the fact that you're overachieving on your savings plan now. So I think our assessment is more of a planning challenge. I think what's really important is of the demand drivers you described, we've got a shared view of what is an absolute deviation from your demand assumptions, and more importantly, how that informs solutions for the rest of this year and next, because presumably those demand drivers will still be there. So I think that's important. As a question, when we met in October, once you deteriorated the forecast, we were talking about potential 5 billion improvement or opportunities to make a 5 billion improvement. So I guess from our perspective, can you and will you improve on 19.9 million this year? And where does that take us going forward for the health?
Yeah, so of those 5 million, obviously this day 5 reporting Monday. Tomorrow we believe we can the position by actually 2 million. That's the 5 million opportunities for the last couple of months being looked at. There's a mix of what that includes, pay, SLA adjustments, some of the work as well, around some new drug pricing adjustments. So that's the positive side. The stretch for the balance of the 3 is still work in progress. Some of those opportunities have trigger points in terms of external factors potentially later in the year. So our process around looking at savings is a continuous process. We've got our own savings board. That's detailed in the paper, so I won't go through that. But we are continuing to look at all opportunities, very cognizant of next year as well. We have got some opportunities in terms of lines of sight and different thematic areas for next year, recognising that we've got.
What does that mean in practice for lines of sight?
So we've got value and sustainability board structure. We're continuing to look at steps around variable pay deal scale adjustments and what that can mean
So
positively
agency
for us.
costs.
Agency, bank, rostering, the whole gambit.
Yeah.
Again, it's just, we've done a lot so far, and our in this agency been non-positive in terms of financial savings. Doing everything we can do more, built areas, should we suggest, and maximise and optimise around contracts like that. More on medicines, more on CHC, specifically more delivery around efficiencies, really. I've mentioned about the bed position and the opportunities around that. We do a lot of benchmarking in Aneurin Bevan, and our outliers are length of stay, impacts on beds, and theatre's performance, and potentially to rationalise our theatres through efficiency, particularly around early finishes, late starts.
You still got a lot of both, haven't you?
Yeah.
Yeah.
I can add to that. So we did have a useful session because I think we realised we need to make, so we can continue to do obvious efficiency, but we need to make some big shifts, particularly take capacity out through improved efficiency, all that shift in the community. So if the re-enablement discussions and that progresses, how does that enable us to shift resources out of the hospital into the community and a quarter of the cost, which is better for the patients? Do we take some of our planning care capacity to deliver the same volumes because we're more efficient? We've looked at how digital could be a key enabler, and we really want to be able to put more money into digital and prevention, but we've got to make some savings to do that. So that's where we've been looking at some of those more big strategic changes, as well as continuing to do our day-to-day value sustainability.
Yeah. Can I just get a sense from you of the extent to which, if I'm working in the health board, if I'm working in one of your hospitals, what would be my understanding of the financial challenge which the board is setting me? So, for example, you talk about productivity. So when you've accepted that there are too many late starts, too many early finishes in your theatre optimization, in your theatre use. So what would be my understanding of the expectations the board has of me in terms of planning my theatre utilisation? If I'm still looking at a situation where there are too many late starts, too many early finishes, that means productivity would be lower than it should be, and it means your financial costs would be greater than they need to be. So how does what we're discussing here translate into that manager, that clinician making choices to do path A or path B and being held to account for the consequences of those choices? How does that, just walk me through what that looks like in practice?
We obviously got, we delegate all of our budget out to our operational divisions and corporate departments. So the accountability starts there in terms of the budget, and also of focusing on overspends. They go through monthly assurances with the COO, and through our own escalation process, those who have got deficit are often called the special budget meetings with the whole executive team to look at what those opportunities are. They obviously got delegated budgets down to directorates, and they'll be held to account for their positions. But then outside of that, we've got theatre utilisation and efficiency group, which meets weekly. There's they go through every specialty. They monitor in early starts, late finishes utilisation, and then targeting those specialties where those variations are, and would be having discussions with the relevant clinical teams about what are the reasons for this. Is it more of a kind of administration procedure issue? Is it about way certain specialties run? So that will be drilled down, and you similarly say there needs a number of workforce groups around bank and agency working with local teams where we've got hotspots on public agency, for example, what are we doing about it? So under each of those thematic areas, there will be structures underneath which will be filtering down.
I don't want to focus just on theatre optimization because that's a very small subset, isn't it, of what we're talking about. But just mindful of the fact that we would all say that obviously we're all setting the goal of getting that better optimized, aren't we? That's the discussion which we're accepting. So given all the good things that you've just described now, what would be your view as to why that is still a challenge which the board is grappling with? Because what you described is a very compelling system for making sure performance improves and productivity improves. What would be your analysis as to why that gap isn't closing fast enough from your point of view as well as ours?
I don't know if anyone wants to come in. It's Rob's been doing a lot.
I think there's multiple factors really. So we've got historical arrangements over multiple sites. over, don't say, I might get this number wrong, I'm going to say about 36 theatres. And it's a twofold really. Operationally on the day, efficiency changes to drive the early and late impacts, but also logistical exercise for us to try and rationalise and optimise how we utilise the theatres we have. So we'll have historical job plans, for example, for anaesthetists that actually we don't have enough anaesthetists to cover all our theatre sessions. So we do something called backfill, which is supporting additional sessions where we have theatre teams available. We don't necessarily have theatre teams available for 10 sessions, for example, at every theatre across all our sites. So it is quite a complicated logistical exercise to drive the improvement beyond the, if you like, on the day operating theatre in front of you on a particular site. So there's that twin track approach to it. What I would add though is for this year we are expecting to see at least 1,000 additional operations to be undertaken through our core activity. So again, there's a positive step, but we need to do more.
If I could add as well, so we've got Ysbyty Ystrad, Neville Hall, and St Willows, where they kind of specialise in particular procedures, and the benchmarking around those that shows them as being highly efficient. And Neville Hall, where we've been trying to drive, so the high volume low complexity list has been really, we need to actually next year trying to do more through those particular.
Which is great.
Yeah, they've also just won one of the awards, so general surgery, where they're running multiple lists with one surgeon, 2 juniors, getting through 16 hernias in a day.
Yeah.
Really fantastic. So there's more opportunity to do that. I think the role went where our more higher acuity, multi-specialties, that's where our bigger opportunity is, and that's where we focus our efforts now going forward.
That's very helpful. Okay. We'll move on now to the second area, if we may. So this is about improving access to services for. And do you want to?
Yes, I'm very brief.
Okay.
Obviously, as I've said, we are really committed to timely and equitable and high quality care. We have done a lot to try and improve the A specialty, and we tried our next patient over the last couple of months, and that has seen quite dramatic improvement. It's hard work getting there, both for the staff and for the manager, but it's been really improved to help ambulance turnover and the length of stay that people have in A&E. We don't want people held in A&E. We're looking further at the admission pathways. We're certainly looking at stroke and, trying to divert them away from A&E altogether and to have a much more effective admission to hospital and other diversion schemes. We still know that the people waiting over 12 hours is too many, too high. And we are working at that, and your teams have been extremely helpful in doing that with us. The challenges have been A&E, and also planned care has been a challenge, like some of the things you've heard. But the reduction in 104 weeks has been significant. Some of the teams have worked really hard to do that. And outpatients over 52 weeks. Diagnostics has been fine, but it's now under pressure with all these outpatients. But they're keeping on top of that, which is really good. Our aim, obviously, is to treat all long waiters by the end of March, except orthopedics, and I know there is discussion. Our delayed transfers of care have actually reduced quite significantly, and certainly the days delayed has come down. That's been really hard inter-agency working, and really quite good transfer methodology now being used so that the range is clear. Medicine is very, very blocked, as you can imagine at this time of year. It's very blocked, but the outlying hospitals have been really playing their part in taking the burden of people who need that extra care. With cancer, the demand, I think I said at our meeting, has gone up 49% in 3 years, which is absolutely phenomenal. The vast majority of the cancer specialties are keeping up with that demand, the problem being lung and colorectal, and we're working with the teams to improve that. But it is a huge demand, and the acuity has also increased quite significantly. Mental health. We've obviously had a review into mental health services, and our aim is that some of that has been redesigned. We have new managers in. We need the wait still to be reduced further, and the teams are working on that, and the quality to be maintained and improved. You know, the acuity of people coming into mental health has also escalated over the past year. But the staff have really tried hard to make real improvements to outcomes for people, as you can see from some of our quality returns. But we are still absolutely focused on doing better.
Okay, thank you. And so I want to talk to you about the Grange, and then I'll ask Nick to address some of the points you made about planned care. So the ED at the Grange has been in escalation since January of last year. And obviously there's been a huge, the board has brought a lot of focus to trying to address the challenges there. And there's been quite considerable investment into doing that. So just to acknowledge all of that. But the truth is, and you've acknowledged this in what you've said, you've still got far too many people waiting for more than 12 hours. And although for a period there was really good progress in terms of ambulance handover, I think September, early October, we saw those lost hours, people waiting too long coming down, which is very positive. But that looks like it's slipped back again. So I want to understand from you what you think is, despite all of those things, despite the focus that you're bringing at the board, despite the investment that's going in, what is the challenge there, which means that ED service is not delivering what you want and what we want through it either. So what are you saying is going wrong there, if I can put it bluntly?
Okay, so I think, as the chair set out some of what we've already done, but I do want to kind of just pick up the improvement. As you said, we've got huge focus, huge, our STEC numbers are up, we've got a frailty team, we've got the new big discharge line, we've got more medical staff in, a range of issues. And as much as, like you've seen, we've seen huge improvements in September, October, and November has felt a really difficult month, which it has been. And looking back, the same time, September to November last year, we lost 12,000 hours in ambulance. This year, we've lost 4,000 the same period. And even November, there was a difficult month. It's half of what we lost last November. So we're trying to hang on to that improvement because it's important for the teams and the efforts they put in. Our over 1 hour ambulances, again, have halved from this time last year. And the 12 hours and the wait to be seen has not seen the same scale improvement, about 5%. Still improved, but not to the scale we would expect. The amount of time people have spent more than 12 hours in the department has come down, and the number of people who are waiting 24 hours has also come down. So even though they still may be tipping over 12 hours, the long length of time after that is reducing, which is something we've been looking at because that's really important for us. Our reduced length of stay is reduced, our delayed discharges and delayed days is reduced. We continue to have a high 4-hour performance across the system, driven really by our minor injuries. And we've seen some really good improvements in surgical assessment turnaround. So there's some really good, but then you think back and go, okay, so how are we still facing all of the challenges that we are? And one of the things our Next Patient 6 weeks deep dive did is really get underneath some of those more difficult system issues that we need to keep addressing. So a more detailed improvement plan has come out of that particular work.
What does that involve?
So some of these, which I'll come on to, so we're getting too much variation across the days. So you'll see the pattern. We struggle at the weekend discharges is a key theme. Monday and Tuesday, we try to recover. Wednesday is settles down. Thursday, Friday is usually pretty good. This isn't so bad. Then Saturday, Sunday, we start going back to the same cycle. So we've got to try and address the weekend discharges, which Jen could come on to. So particularly looking at week criteria discharge, because we know we haven't got the same capacity around on the weekends. We get quite a lot of volatility in demand and acuity throughout the week, and that find it difficult to manage that volatility and recover. So, for example, we've had, particularly recently, I mentioned it, ICU was full, which is very rare. Resus is full. High gastro demand comes in a small period of time, or stroke demand, and our ability to then de-escalate and get back into that normal business seems to pose us. So we need to put more resilience into the system for those. Acute medicine is a key issue for us at the Grange. So a lot of the blockage in ED, the reason we can't get the ambulances in is we've got patients in the ED who need to move on into acute medicine. This acute medicine that we see the biggest congestion. So that is a key focus for us around how do we, we've got an issue, I think, around processing power in acute medicine at the Grange, and being able to then move them on to the right part of the system. So they are the main issues alongside transport and diagnostic delays, which we're working on.
So can I just ask, so I just want to be clear, I'm absolutely not saying that there has been no improvement. So it's helpful that you've set out the areas where so I absolutely want to acknowledge that. And I know that staff listening will hear a lot of the discussion today being negative, and I also want to acknowledge the work they do, but understandably we're here to get under the bonnet on the challenges. So so despite all of those things, and there are a number of challenges which you described that still need to be fixed. Do you think there's an underlying cause? Do you think there's a challenge, and is the hospital recognising the priority which the board has set on solving this as a system? What's your analysis of why these things aren't making more rapid progress to meet your expectations as well as ours?
But I think we need to get onto the discharge side of the business, because ultimately flow out of the system is the biggest issue. And I would say until recently, it has been all about flow in the discharge side of the system, because we would almost at any point have 20 to 30 people waiting to leave the Grange to go to another hospital. And then those other hospitals are full with patients who need to go home or on to another. I would say in the last 6 months, as we've made some of these improvements, there's been more days where there's less people waiting to leave the Grange, but the demand for that hospital with those specialties is greater, which indicates that there is an acuity in the demand issue. And one of the things
demand at the other sites,
no, in the front of our Grange, and when the GIRF team came in 2024, they picked up about some of the demand we were facing as a system, and the average admission age of the Grange is 44 years old, which they were saying demonstrates some of the challenges of the population. So it's even more reason for us to get underneath the whole prevention, the upstream work, because that's where the biggest gain can be. So I think as we're making improvements, we are seeing a bit of a shift in demand, but that's not universal. There is a lot of work we can do in the other hospitals around discharge, admission avoidance, which is where huge amounts of our effort are in it, as well as some of the processing power within the Grange that we need to address.
Could I just add to that? We've also recently made changes in order to improve the processing power by moving more of the acute physician respiratory consultants into the Grange, so that you get a higher level of intervention and review to ensure that the facilities and the people that we have are being used to them at best effect. So we've just done that.
Thank you.
I don't know if Jenny wants to come in on some of the discharge review, and I think that later.
Just to come back to Jacqueline's 3 points, we've taken the 6 Girls programme very seriously. I'm the executive lead for that, and obviously we focused on the total pathway, not simply the discharge pathway. So we've done a lot of work to ensure that we have supported our community teams to develop. We've added additional clinical resource to those teams to ensure that they are resourced to be able to pull those patients out of the system as early as possible, linking into obviously the SPOA developments and some of the developments that we're doing with WAST around admission avoidance. So those pathway type approaches, and we've developed really strong partnerships with our social care colleagues as well in that space. So we've got a programme of work called Emergency Care at Home. Through that, we are looking at the efficiency and effectiveness of what we call our community resource teams. So they are our integrated teams who work in our neighbourhoods and communities.
And what have you seen making the biggest difference so far?
I think what's made the difference, I think, has been that we've extended the hours of which the referrals could be made. So previously the referrals would stop at around 4 p.m. We've extended that to 8 p.m. So there's additional time to get those referrals in later in the day. And obviously through the further faster funding, we've made sure that our community nursing teams are obviously focused on those patients most in need. We've got we're developing an emergency care at home pathway. Essentially, it's admission avoidance, but working with our social care colleagues, being careful around language, and we've really looked at that revised front door model. So trying to pull people out of the system before they get into hospital, but if they do end up at the front door, as Nicola said, we've got the community assessment lounge, which is integrated between therapies We're the only health board with a frailty nurse consultant in Wales, so she leads that service. Obviously our therapy colleagues as well, and social care. So there's
Just interrupt you a second. I'm trying to get a handle on what this is all sounds very positive. What I want to get a handle on is what you feel is working best out of it, and what, you know, what's making the biggest impact.
So we've got an integrated pathway. We've had that for about 9 months. I think putting a physical site in place, it's only been in place for around 6 weeks, so it's new.
Okay.
It's developing, but the early data is promising. I think we need to wait a little bit longer to see that, but I think the pull into that department, so pulling people out of our acute system into a system that has health and social care working together to find alternatives, is positive. And whilst the numbers are small at the moment, the patients they actually turn around is high. So if we can increase that volume, I think that will make a huge difference. And we also have something called a hospital to home service, which is really about pulling D2RA into the community. So taking people home, providing healthcare support worker support in the home, and doing the assessment at home. And again, the indications are that we are lowering those care packages, not increasing them. So again, that's really positive. We've gone further with the populations at risk, so not just focusing on the top 20%. We've started work looking at how do we identify the groups of rising frailty where we can really intervene early. It links with our place-based care programme, but we've seen some pleasing results in Newport where we have an MDT approach who coalesce around the rising frailty population. It's led by nurses and an OT, but obviously clearly involves the pull-in from primary care.
I'm keen just to get just one. It all sounds very positive, so thank you for that. I just want to, and I'm bringing Nick in then, just to get the sense from the board, which is, you know, you're describing very eloquently lots of very good work that's going in and doing things that we all know will make a difference, or should make a difference. I just want to get a sense of what you think would be the things which the board will do, which means that we're not having the same conversation in 3 months' time. That's really what I'm trying to get at. You know, there's a lot, you're describing very clearly what the additional work is that's in the system. What do you feel as a board is going to make the biggest difference so that we aren't having this conversation?
What have I reflected is sometimes are we trying to do too much? So that, you know, how do we identify those high impact changes? And also because we've done a number of things, is trying to work out exactly which ones will have the greatest impact and which ones are not having the same. But we have got our new ED waiting room opening in the next few weeks, which has got double the capacity, which improves patient experience, but it also does have additional assessment spaces and triage spaces. So hopefully will enable us to have a bit more capacity at the front end. The work that we're doing around the discharge side of the system now, so the next fortnight we're hoping that will start seeing that kind of improved flow. A single point of access we've only recently just put in October, and the work that we're doing around acute medicine and senior, obviously our new medical director has just started with us 5 weeks ago, and it's great to kind of have some fresh perspective in terms of where, and I know she's been working with colleagues at the Grange in terms of making sure any issues, particularly medically related, that we can, and brings a lot of experience from Bristol in terms of where we've addressed that. So
we had a chance to meet actually the other day.
Yes, we
Good
did.
to see you. I'll bring you Nick.
Yeah, just so on the Grange, I think it's worth recognising that you opened a big brand new hospital in the middle of the COVID pandemic, which was intended to transform your system. It's before it was named the Grange, it was the Specialist and Critical Care Centre. Everything you've described today seems to suggest it is regressing into almost a general hospital, a big general hospital, district general hospital, as it needs to be called. So my question is, do you think you've got the model right? Because if I look at so you're absolutely right, you've got acuity issues and you've got demand issues. The acuity issues are in those patients who should be coming to the Grange, the 49 to 65-year-olds. But actually your demand issues are in your older population. So the only increase in admissions through the Grange in the last 12 months is in the over 70 category. Should they be going to the Grange? Because they get an added length of stay with the transfer, the wait for the transfer, and then we all know that moving a ward or moving a hospital adds at least a day to people's length of stay. So, and we've now put more respiratory in, and we put this in. It, to my mind, you're describing changing the model because the model isn't working. You've invested huge amounts of money in additional ED consultants, yet they still can't see a patient within 2 hours. So I'm unsure whether that's the right model, and whether by focusing more effort on that is just actually exacerbating the problem.
Yeah, so I may bring Seema in a second. So I think the hospital works extremely effectively for specialties, for cardiology, gastroenterology, emergency surgery, some of our critical care, all of those, the evidence shows they are better as a result of the centralisation, paediatrics, obstetrics. Our RAMI has improved from the time we pretty much opened it. So you can see the system is doing what it intended. We still do acute medical takes on 3 of the hospitals. So Nevermore, Royal Gwent and YWF all have an unselected, you know, so the less complex medical patients, particularly those which will be elderly. And we've done more work over the last few years to make sure that particularly falls or there's a falls pathway. So are we sending people to the Grange that could be seen in those other 3 hospitals? So we definitely have some new pathways which try to avoid people coming to the Grange who don't need to be there. Do I think there's more opportunity to do that? Yes, I do. And some of that, these are patients who come to the Grange who are elderly and frail, but will have something more acute related to them, or they've had a fall, there might be a fracture that need, but they are then more complex when they come in and how we support them to get back to the right place. So the COTI frailty links to acute med, and can we continue to sustain 4 takes? And then how can we remodel our service with COTI frailty is one of our priority work streams going into next year. And Seema will be obviously, Seema is also a COTI consultant by background, so obviously he's got some huge thoughts. So I don't know, Seema, you want to say anything about that? From
Yeah,
your
so,
reflections so far?
I know all too well the things that we're all concerned about in terms of patients who are frail and the deconditioning they face if they get into the wrong place for some of the issues that are, you know, they really do need some support in, but where that is really important. I think I want to say that there's already active work going on looking at the older person's pathway, and colleagues who are coming together across primary and secondary care, and our community colleagues and our voluntary services as well. And there's also an acute medicine pathway group that's been set up again to refocus on how we can reconfigure in a way that meets the needs of our population. I think we're building on a really strong group of big clinical leaders who have been really engaged in all the work we did to set up the Grange model. But it has been now, 5 years since we opened the Grange, and as we've said, the demand is changing, the population has changed enormously, and so we do need to think about delivering services fundamentally differently to how they're set up now. So I'm really confident that we've got the right people already working on these issues, but as we move into developing our clinical service plan on the back of the strategy that we've just launched, that will really enable us to start coming into a phase where we can really look at that prevention piece along through the different ways that we can manage patients. So this is the 5th week I'm in the health board. I'm feeling positive that we've got people who really care about this, and it's definitely my priority.
I definitely want to come back to the clinical plan in the next question, actually. But
Okay, can I switch to cancer? That's all right. So I just got a question about up by nearly 50%, 49% over 3 years. Has the conversion rate changed?
No, not hugely. So since the 1920 COVID, we've seen from 29,000 cancer records for 45,000. So it's enormous. And we had outlier really. I think the average for Wales was about 16%. So again, trying to get underneath. It's a good thing, isn't it? James always tells me increased referrals is a good thing, but the conversion hasn't changed hugely. We're fairly in line. So it's suggesting most of them are appropriate referrals. Yeah. There are some tumour sites that have seen a greater increase in them.
I wanted to say mention some of the sites that have been improved, but the gynae cancer levels are pretty low. They're very low. So what's going on there?
So we've had some specific staffing issues in gynae because we did need to be a step change because of the pathway for events were bleeding and that was being fast tracked. But a number of staffing issues have thrown us off. Also, we've got some plans in place to propose additional staff and
when you feel that,
issues.
when you think that's going to get into
I'm discussing with the team recent 3 weeks as I hope within the next we should start seeing improvement each month over the next 3 months.
Let's move on then, if we may. Thank you. To the next item, which is how we are adapting services for future, both in terms of demand, but also in terms of the kind of services we provide. So,
great question, we think, Liz. A very broad question, of course, and could start by saying that probably all of the changes and improvements we're making will make a difference in terms of the future. In terms of trying to look a bit further ahead, I mean, we are broadly we understand and what we think we need in place are 4 headings really, and 4 pillars, if you like, of the dealing with this. We're looking first of all at strategy. In terms of, it's no point in trying to think about the future unless you have strong strategy, strong direction, strong route map to know where you're going. Digital transformation, the digital piece we think is absolutely key. Population health, then another huge area for us. And the final area really is primary care, community care, trying to build a much more stronger and effective base in community. In terms of strategy, well, we've just launched a new 10-year strategy. Spent a lot of time in terms of engaging people on the new strategy. We didn't sit in a room and write it. I mean, we've engaged across the system on it, basically to try to get sign-up, try to get people on board with the strategy, so that it will actually mean something when it's actually on the street. So we are working closely with partners to establish an approach which is focused on the determinants of health, truly recognising our role in keeping our community well and not just treating illness. I mean, that's the whole focus of it. So we're very much taking a public health approach from social, environmental, economic and cultural elements. We are shifting the focus to neighbourhood health, building on the assets that exist in our communities. We've developed a joint assessment which has been adopted across our strategic partnership. This, alongside our cycle of community conversations, will offer, we think, assurance that all that needs are based, things are based on a need-based approach. We also welcome and engage well, we think, with national strategies and national drivers. The Women's Health 10-year plan, for example, we've received very enthusiastically. We have the Women's Health Hub coming on stream, and again, we've done a lot of preparatory work across the system to engage people with it. Moving on then to digital transformation, I mean, it's you can't do very much these days unless the digital piece is centre stage. And we think that we've invested fairly heavily in terms of capacity and in terms of kit, in terms of digitalisation. Few of the areas just to touch upon to highlight. We think we lead in the way in the use of the national data resource for the development of a solution to undertake demand and capacity management. We have an ambition plan, for example, to migrate our data warehouse over the next 12 to 18 months. We see the continued development of the NHS Wales app as absolutely crucial. We have a high number of patients registered to use there, and we are well advanced in terms of numbers, in terms of referral notifications and appointment details available to patients through the app. We've just completed a procurement process for the new mental health system, and we think that will actually pay pretty serious dividends in terms of the continued development of a mental health service. Turning now to what we think is probably our biggest challenge really, and that's population health, improving population health. I mean, we have incredibly large gaps in terms of life expectancy within our patch. I mean, it's 13 years from the least to the best areas really. It's a very, very sobering thought. And in terms of healthy years, the stats are even worse, particularly for women. So I mean, this is undoubtedly one of our major areas. We have an imperative to address the inequalities, to address unacceptable levels of avoidable deaths and prevent ill health. In any event, we feel that unless we can actually intervene and change this demand curve over the years, then probably there isn't any health system that would cope in the future with current levels of demand estimated in the real. But that's where we see this as pretty serious and important. I guess the question then is, well, what are we doing about it? We know what the issue is, so what are we doing about it? Well, we are working across the life cycle to address the inequalities. We're doing all the things you would expect us to do. Smoking cessation, weight management, diabetes prevention. We've got lots of things going on in that space. But there is a difference, we think, throughout the board and throughout the localities now. And the difference really is that there seems to be a much more of a renewed impetus around this. There's more energy around it. People are far more engaged in it.
What's happening as a result of that level of engagement?
Well, one of the big issues within improving health, of course, is that's not within the sole gift of the health services. So we are working very hard across the system with our partners. I think, are the first area where, for example, where the Public Service Board has adopted Marmot principles, and that's not just, they don't just talk about that; it is changing the conversation. So we're now starting to get on the same page with partners, particularly about what are people's priorities, what are the priorities of our organisations.
Can I just ask you, just on that, and this isn't a challenge which is specific to this House Board, but there's so many of those of the Marmot approaches, and we want to be a Marmot nation in Wales, inspired by the work that's happening in the Gwent area. But so many of the interventions and ways of working have quite a long response time that they're necessarily given the challenges that we're trying to address.
Yeah.
How do you know the stuff you're doing is working if in that context? How can you tell now that the approaches that you have in place are ones which are going to have that effect in the longer term?
Could I just describe what happens at the PSB there now? Because that's the question I'd always thought. Well, this is awfully long term, how are we going to do it? Each one of the elements that will make up the Marmot County is now presenting their plans, and they are coming forward with the very short term stuff that we can all adhere to and where we're going in the long term. So we have managed to get a short-term 3-year focus on, okay, this is what we're all going to do for the next 3 years. I mean, money's always a problem, and people will argue about that. But the principle of what we're trying to do has come down from just being 25 years' time, we will look like this, to much shorter, and that's the active discussion of the PSP.
I know that Isabel and Sue will want to come in on questions here. So can I just ask one question before I ask Isabel and Sue to come in? And as it happens, I had a message on Twitter this morning saying, so it's very topical. Somebody had been to the Grange and said, staff there were fantastic, but that the pressure there was significant. I'm not going to go back to that conversation. We've had discussed that. They were saying, well, why don't you reopen the A&Es elsewhere? So, and obviously I'm not advocating for that, but what it suggested to me was that people don't yet have a clear understanding of what the strategy is. And I understand that is challenging to make sure people understand that, obviously. But the question I have really is, what is the timescale that you have for making all the decisions that you need to make in relation to Neville Hall and other sites, so that you have completed the shift that you're trying to make as a health board and are then able to articulate that publicly the way which people might understand? How does that look?
We have just started the refreshing of our clinical plan, and that's going to take, I think, it's 18 months to finish that.
Yeah, so we're in the process of building on the clinical features, the new strategy. Now there's a opportunity to kind of reset our clinical plan. I think there's a wider communication, and something we've kind of really battled with. How do we regularly get communication, which is just open Royal Gwent and Neville Hall A&Es again, it's much easier, and that understanding that an A&E doesn't come on its own. You need the whole infrastructure, you need the theatres, you need critical care. So we've been trying to consistently get that message out, and also at the right time, how do we try to promote the benefits of what the Grange has brought to the community that we've got in some of the quality and safety metrics. So again, we were hoping as we kind of see continuity improvement, we've got the new waiting room, some new investment, that we do a bit more of a broader launch and then build on the strategy work in terms of a communication over a period of time.
So what was the timescale you're working to?
So the timescale within the early, but probably around the next 18 months, isn't it, in terms of having a more formalised clinical plan that kind of replace the clinical features that we have into.
But we've got to keep up with this message about where you go for care and attention, and that includes the GPs and the the ambulance service and everybody. We've got to keep it up.
I'm sure we'll come on to that. So, Isabel.
Thank you. So I welcome very much the strong focus on prevention and on reducing health inequalities in your clinical future strategy and everything that you've said so far. You've provided information in the pack and in the discussion so far this afternoon that highlights those inequalities. So, for example, you've highlighted that 1 in 3 deaths are premature deaths in your area. That would mean that there are a large proportion of those are either preventable or treatable. Recognizing, of course, the importance of the wider determinants of health, how will the board assure itself that the services that you are providing, that your clinical services plan is helping drive reductions in health inequalities? So it would be useful to know that and to know how the Director of Public Health will, might also be involved in the development of the clinical services plan, as well as I'm sure the medical director and other clinical leads.
Yes, so I'll bring Tracy and then Stephen in if that's okay. So I think one of the things we've tried to do from the strategy, recognising it's only just been launched, is look, how are we going to measure success of this? And what are fairly a smallish level of metrics that will give us an indication that we are having the impact that we're expecting, and they are set out in the strategy, which, and again, how we measure some of the impact on population health is key. Tracy, in terms of the joint strategic needs assessment that we've done, gives us a baseline with which we can now monitor going forward. But Tracy, I don't know if you want to come in on that particular question.
Thank you. I think for me, some of the work that we've done over the past 3 years has been very much about identifying the needs of our population, being able to find a route through a prevention pathway to actually keep people well, as well as obviously treating those people that are in poor health. We know that only about 12% of our population are in the health system, so that view of the 88% that are in our communities that we need to keep well. The 1 in 3 deaths that are identified in last year's DPH annual report are the preventable deaths. These are the people that we can really help keep well. And whilst we would want to see a life course change, so what we do, best start in life and making sure that we've got healthy children will obviously give us a future generation of people living in good health. We know that it generally takes a generation to prove a point around public health, whether you look at the smoking ban, seatbelt wearing, and we won't have a generation to prove this, but there are step changes. We know about 1 in 4 strokes could be identified through better blood pressure identification. We could actually prevent 1 in 4 of those strokes, and we could see that change very, very quickly.
But what's happening as a result of that?
Yeah, so we've introduced a hypertension pathway. So what we're doing is working across primary care, secondary care to do linked data as far as we possibly can in the absence of a fully structured population health management process. And we're also linking that now, working with 2 of our local authorities to begin with, to do pathfinders to understand where the risk is identified within our population, so we can start and target at-risk populations more purposefully, so we can start to get these programs on board. The hypertension, we're about 9 months into that program now, and we're seeing really good results with that in terms of identification and getting people on treatment that may well not have presented. But that has been a very manual process through our GP partners to identify that at-risk population. So as we get more sophisticated with our data landscape, we'll be able to do that more systematically. But we have so many opportunities across cardiovascular disease, diabetes prevention, a huge range of things we can put in place to try and tackle that, not just premature death, but premature morbidity as well.
Thank you.
So I think you have an opportunity with your excellent joint needs assessment, which I've seen, and the fact that you're embarking on the clinical services plan to think about how you integrate this into that plan, and you have an opportunity to integrate better your work around public health, primary care, as well as secondary care in a more integrated view. So it would be good to see how that might develop in future.
Thank you, Secretary. So Tranquil, Chief Nursing Officer. So Phil mentioned your the life expectancy and the healthy life years that are reduced for women in your area. I know we just talked about your gynae cancer rates needing some attention. So I'm just wondering how the board is assured on the Women's Health Hub that is coming in. Will it be online in time? First thing. Well, how will you know it's successful once it's there? And if I were using the services in the Women's Health Hub in your area, what will feel different for me next year, this time? How will you know that I'm getting a better service than I did a year before?
So so we're really passionate about women's health. It's
so many of them on the board.
the data that we see is that women's health expectancy is reducing for the first time. So I know we've got big inequalities in the Gwent area, but Tracy's been leading on the women's health plan, so I'll bring Tracy.
Yeah, no, really grateful for the opportunity. I mean, women's health is already listed as one of our priorities, but so grateful for the emphasis then that the women's health plan has been able to give us on this. And we've really looked at this very, very carefully. And of course, we've had that benefit of being able to triangulate this with the needs assessment. We're also doing the women's health discovery report at the moment and really looking at those vast inequalities that exist in women's health. I mean, Bill's touched on that in healthy life years. In 2 of our local authority areas, that is as much as 25.5 years between the least and most deprived. I mean, which is huge. One of our local authority areas have women living with 2 or more comorbidities from the age of 48. So we know we've got to do a lot around this. And it's not just about the health causation that we can treat, but also looking at the social determinants. We know the drivers around domestic abuse, we know the drivers around poor living conditions, employment, economic well-being for women is very, very different. So really taking a vast view. We are working along the pathway in terms of launching our hub. We're hoping that we'll be able to have a successful ministerial visit in the next few weeks, which will be fantastic, and how we take that forward. Some of the early indicators through the discovery report is starting to pick up associated issues such as PMS and mental health around, through hormonal causation. So we've actually now commissioned a piece of research around that, so we can have some really good research-based information to actually drive change and inform those services. Because what we're really keen to do, that this opportunity that we've had through this investment for this Pathfinder, that we can actually build sustainable services that are really going to tackle the inequalities that women are experiencing on our patch. So we're just seeing this as such a fantastic opportunity. So we don't want to waste a moment of it.
Thank you. So you sound really passionate as a board, and thank you. That's great. So the question was, is the board assured that the hub will be open in time? Great. How are you going to measure it? Because that's what I'm really interested in. Will it be life expectancy reducted so it improves? And how long do you wait for that? So what will next year feel for me when I come and use your hub?
So I think first of all, the board a paper went to the board meeting last at the end of November, which was describing all about plans for women's health. So the board has had a detailed update around that. And Tracy, I don't know if you want to describe what it'll be like this time next year from a women's perspective.
Yeah. So what we've established is the indicator framework, which will give us our metrics, and we're looking at those both on the need, but also the expectations that are obviously coming from the Women's Health Plan. So that indicator framework is being established. So that will go live as the hub opens. And obviously it isn't just about the hub, it is about women's health, because what we don't want is it to be a hub, because if it is just focused around that, there's potential inequalities with that. We want to make sure that women all over our region can access good healthcare. So that indicator framework will come live.
Thank you, Madam Secretary. I guess the thing I'm looking for is that I'd be able to, as a woman, I'd be able to have access faster. I'd be seen quicker. I wouldn't have to be seen 17 times to be. So those are the things I think the board should really consider in its opportunities to really show its measures a year in.
And in terms of, there's a lot that you've already done in terms of service reconfiguration, obviously. Like I said, you've opened the huge hospital, and there have been quite significant, very significant changes to the geography and the offer of the site as a result. And there's more to come, obviously, in the way that you described. Just wanted to get a sense of how clinical leadership looks in all of that, because we haven't discussed that very much in the plans that you're talking about. So how will you describe not just clinical engagement, but clinical leadership in reconfiguring your plans?
Yeah, so we obviously got a clinically, our divisions, our operational delegated divisions are all clinically led. So we've got strong clinical leaders across our system anyway, with clinical directors. But SEMA is with a fresh eyes to looking at this clinical plan. We've been developing a clinical, looking at how clinical leadership and engagement come together as we drive forward the clinical plan. We've already done quite a lot, even since the Granges opened. We have taking certain actions around the other hospitals in terms of minor injuries, maternity services and stroke services, and all of those will be clinically led. You know, all of those have been driven by what the clinical benefits would be. And as Tina mentioned, some of the programmes already in place around 40-80, the older persons pathway, are all currently clinically led. But Tina might want to come in with a bit more kind of granular detail around.
Yeah, so it has been a short week since I've been here, but what I see is really strong clinical engagement and leadership. So we've just already alluded to some of the awards that that colleagues have been leading in terms of interventions like the fragility fractures identification with 200% increase in case finding, leading to, particularly with older people, a tripling of treatments. That has all been through clinical leadership and engagement, the high intensity lists at Neville Hall, as well as reducing the time for treatment for head and neck cancers. So I've just been really so impressed with the clinical leadership that's already in place. I myself personally meet the divisional directors on a weekly basis so that I can understand what their challenges are about, but also what they're really wanting to improve and their ambitions. And
what are they telling you what they want to improve?
So, I think they want to see that their services are delivered differently, and that they recognise from our strategy that what we're delivering now needs to look different for the future, particularly around our patients having their care in a place-based way, some of the work that Tracy is leading, and then being able to have the good outcomes that we know that we can achieve in across the health board.
Have you been able to get a form of view about what this looks like on a regional basis? Because obviously increasingly there's a new board, a regional board established in the southeast. There's already work happening with 2 neighbouring health boards to in the region around shared waiting lists in some areas of surgery, and obviously we all know that there are sometimes challenges in aligning clinical practice between different footprints. Have you had a chance to make that assessment yet about how that's working?
So, the Cabinet Secretary, I come from a role where I was involved in and led 2 organisations coming together along a joint clinical strategy. So I know the tensions that can sometimes be there, as well as the shared opportunities that our clinical teams have. We talked about the development of the clinical service plan. I've already spoken to the medical directors in the neighbouring health boards about how, as we all develop our clinical service plans, they have to be coherent between us, and to really grab the opportunities that are available for us. And so there is that the relationships and the connections are there at the medical director level, and also at the level of teams as well who are working together. No doubt we have to still strengthen them as we work through some of the challenges that we have. But when we look at the fragile services that all health is, the way that we can come around that is by looking at working closely together and what our population in the southeast needs.
I agree with the ambition. And you're describing the end result very eloquently. I'm trying to get a sense, and it may be unfair to ask you, so it's only been a few weeks. So if someone else wants to come in, that's obviously fine. But I'm trying to get a sense of whether you foresee challenges in some of that regional working as a result of aligning practice across the health boards. What's your sense of that?
I think actually it's made more remarkable progress than I would have anticipated, because these things are really quite critical.
Yes.
And getting a consultant orthopaedic to give up his favourite prosthesis is not easy.
But have you accomplished that?
Yeah, we're getting there. The head of orthopaedics in Aneurin Bevan is leading the 3 health boards on orthopaedic surgery and its readiness in respect of the Llantrys Health Park and our own practice, and is really making very, very sound progress at the moment. He's not quite got to the prosthetic end of the business, but that will have to be part of it, because any of us who run these major old orthopaedic centres, it has to be run really efficiently, and there has to be absolute unanimity the constantly really good outcome.
I'm not hearing you signal any concerns about the ability to manage that, so.
Well, there will always be a bit of juggling along the way, but it has made much better progress than I had.
Yeah, I just want to ask, so one of the services we have successfully resolved as a region was vascular surgery.
Yeah.
It took many years to get there,
Yeah.
and it was challenging in terms of trying to bring the different health position, but we have achieved that and we are seeing the benefits of that. So I think we've demonstrated it can be done. And like Anne, I've seen a real kind of enthusiasm now around the Llantryston Health Club with orthopaedics. I think there is a consensus. This is an opportunity for us to organise ourselves differently. I think the challenge will come when you start getting into the detail of when you're then getting into the workforce plans and where care will be delivered across the system.
It's essential to deliver.
Yeah, absolutely. But I think that the fact that we've got a general consensus about the direction of travel and a commitment to that is significant progress from where we're coming from. And I think, you know, the teams are coming together. And even while we're planning for the future, we've already been sharing best practice between us and have already started implementing that in some areas. Small scale, but they are steps in the right direction. But I'm not underestimating that it will be challenging when we get into the implementation phases.
Okay. Yeah, just linking that to the sort of both the diagnostics and the other service aspects. I suppose we need to see the evidence of how that best practice that you describe is delivered in your local services as well as the new, because I hear what you say about your orthopedic lead and these all for a modern new unit run highly efficiently. You've got a very good cold facility in St Mullers which doesn't run fully efficient, and you've got opportunity within orthopedics to really drive further activity, further change in improvement for the public. So, I mean, I don't want to get into waiting list necessarily, but you will deliver this year 8,500 orthopedic procedures in England, which is more than you delivered pre-pandemic, yet you can't eliminate your 2-year waits. So I don't understand the correlation between that and then we're moving to a regional facility because we need to expand demand and capacity issues, etc. So where are we with the implementation of what is right for the patient now as opposed to the future? And that links very much to all of the work around prevention and all of those sorts of things. What is the person in Gwent who lives in Gwent, their interest, seeing in terms of that improvement in services in Gwent? Because what we've described today, we can't see.
Yeah, everything from that point of view. So in terms of St Mullers, that I know from the good visit from our own experience, it is seen as one of our most efficient units because it is more of a cold, the less complex patients, and you know some of the arthroplasty kind of length of stay has been pretty remarkable from some of the work they've done. So, and I know that was recognised by Bwrdd. I know some of the health boards have picked up the St Mullers model into their areas. That was one of the examples I was talking about learning. Arthroplasty is our biggest challenge in amongst, which is why when you get into the 104 weeks, there's a bit on spines, but that's our biggest challenge. The work that was done to inform the regional LHP shows that there is a significant gap for arthroplasty, including Aneurin Bevan.
LHP being just some health.
So yeah, so that shows there is a significant gap in demand and capacity, and there is some efficiency opportunities for all of the health boards, but it was relatively small in the scale of the demand, and we would not bridge that gap on efficiency alone. So I think having that kind of external assessment has been really helpful. That's not to say we shouldn't drive forward those efficiency opportunities in advance of that, but it is going, unless we find a different way of managing some of those patients, there is an ongoing demand and capacity that's been validated for that capacity.
Yeah, absolutely. And look, I'm not going to get into a debate about the relative levels of efficiency. I'll just give you one number, which is your stage 4 treat and turn rate is 30% in Aneurin Bevan. The best in Wales is 58%. The best elsewhere is 75%. So there is clearly opportunity to which we need to go at, and that's what we've got to get to in terms of what the public see in terms of they've waited the longest, they expect to be, treated first, if you like.
Thank you. We're going to move on to the last of the 4 items now, which is how we strengthening how we run the NHS and in the context of Aneurin Bevan, what is happening at a local level. So, and who's going to help on that?
Well, obviously, to deliver high quality care, we really need robust leadership, which is skilled. We've got to have effective and accountable management and good workforce planning with good quality and financial controls and a positive culture within the UK. We've recently refreshed our people plan on the basis of better health and well-being, better working lives and better future workforce in terms of stability and promotion. So that I think has reinforced our real desire to support staff and develop people. We've already made substantial reductions in turnover and in vacancies. Sickness is at the same level as most other people, but we're not content with that. We want to ensure that that is taken down. So we have put a lot of time, effort and facilities into the workforce feeling well, that well-being system we have, and that seems to be very much appreciated. We've invested in more support services for our staff so that the on turnover is really quite reduced. So we feel that leadership and succession planning is vital. I'm very, very pleased that HEIW has taken up the mantle of improving management training and development, because it was in a very sorry state before, and we can now see people who are willing and anxious to take up roles of seniority within our organisations to lead things forward. Sarah and Nicola have put a lot of time and effort into developing really good management development schemes for people like clinical directors and the general management, because they are going to be the rock on which British care is founded. We've also reformed the culture statements because they were a bit sort of long and you could never remember what they were really. And so we've just gone down to 3 new values which build on the old ones of kindness, integrity and respect. And we expect everybody to get it. So we believe very firmly indeed that leadership and management is absolutely key to allowing our staff to really make the most of their skills and develop them properly for our patients.
Okay, thank you. And so you said that you'd been reforming the culture statements. I wanted to touch on reforming the culture more broadly. And in particular, there have been serious concerns raised about leadership and culture in the mental health service with an internal investigation. And obviously the enhanced oversight which the board has consequence of that. I wanted to get your view as a board on how confident you are that those issues have been addressed and resolved. And secondly, what insights which you gained from that, which you have applied elsewhere to make sure other parts of the organisation benefit from the learning that you hopefully have had in the context of mental health services?
Well, we did have concerns about mental health services, but the board itself, there were a number of serious incidents that came in a club which we thought was just unacceptable. So I asked for an external review of our mental health services and its culture. And from that time, it was very helpful. And it was quite reassuring to realise that actually we were already. So we have refreshed the leadership. We have ensured that there is plenty of education and training. So particularly in terms of speaking up safely, that staff felt more enabled to do that. And that certainly has come through. So that the general quality of care could be improved. And we've seen a rise in the performance outcomes in mental health. We have applied the lessons we've learned to other areas where we felt, well, it just might need a bit of a change or reinforcement, and the work that Sarah and the team have done in terms of actually implementing a people plan that makes a difference to the people who are working for us, as I think now being seen to really promote and improve care for patients. It was quite helpful having an external view on the mental health service. It was also quite helpful to realise when the report came through, we had already initiated some of the improvements, which was gratifying and good. But there were other things that were really helpful, and it just reinforced what our own views were about how to take forward change.
And so I'm taking from what you're saying that the recommendations have been implemented in full,
Yes.
effectively.
Yeah,
And you've de-escalated. I know that you
we
did.
de-escalated. And you can see the rise in the level of conformity with really good practice. We've set up a mental health committee to keep an oversight on that really important, very vulnerable patient, very difficult environment.
Would you say then that there are examples elsewhere in the organisation where you've taken some of that learning and seen similar benefits in implementing them in different contexts, and other examples of that?
Well, we've taken that learning into our people plan, so it's more generally applied.
Right, so Director Workforce and OD. I support everything that Anna said, but in terms of that cultural shift and that cultural change, I'm sure we'd all agree that that takes a considerable amount of time. And more certainly in a service such as mental health and learning disabilities, where you've got a wide range of professional backgrounds and also a spread across wide geographical area as well. So there'll be some history in terms of those subjects which we need to unpick. One of the most important long-term pieces of work which has come out of the review and has been fully supported by the board has been for our Assistant Director of Organisational Development to spend 50% of this time with some support directly with the mental health and learning disability team, but to enable long-term, probably for the next 12 to 18 months, culture review with some action in terms of deliverable outcomes following that. To undertaking the first couple of months' work, analysing the current situation, taking a lot of time to speak to staff, understanding their experiences, understanding that in the context of the review and what we know more broadly to engage in the plan. And we're just at the stage now where we're able to develop the detailed action plan and take that forward. But it's making good traction within the senior team, the leadership team, and teams on the ground.
Can I just ask you, I'll bring Sarah in a second, but I take the point entirely that changing culture this isn't something which can be achieved overnight for reasons which we would all understand. But just to get a sense of you, you're all speaking very eloquently and persuasively about the change and the positivity from it, which is good. If I was a member of staff, what would this feel like to me at the moment?
If you were a member of staff in mental health and LD in particular, in the majority of teams now will have had contact with the people undertaking this work. We're doing it in conjunction completely with the senior management team, because that's very important that they own that and drive that, the sustainability of it. You will know that you've been spoken to, or members of your team have been spoken to. You've had an opportunity to input into that, and that you'll be followed up with feedback, and there will be regular communication around the next.
I think you'd say it's too soon at this point to assess the broader effect of it, but
yes.
you're saying you're confident that there's been concrete steps which you have.
Very much so. I'm very much encouraged by the new leadership team in terms of their engagement and their active professional and managerial leadership in the review.
Thank you.
I just think, sorry, just in terms of the learning question, I think one of the things we've learned is where we perhaps pick up issues where there could be some unrest or culture that there's opportunities for staff to come forward. We do maybe listening reviews, give people the opportunity to speak confidentially. So really kind of responding quickly to where there could be any concerns that we're picking up so that staff have got those opportunities to come forward in a very confidential and safe space. So, you know, that is one of the things I think we've learned from it, and we are applying that to other services in the organisation where we possibly pick up any issues.
I'm not asking you to be specific, particularly on this question, unless you wish to be relevant. Would you say there are already examples where there have been changes to the service or changes of any sort as a specific response to staff responding to those new opportunities? Or is it too soon?
I think it's just giving staff the opportunity to clear any concerns. We've done it in a number of specialties where we feel that maybe the staff are under particular pressure or there's a bit of unrest, to give them that space to speak to people, that we can then make sure, is there anything new that we didn't know about? Is it already in line with some of our improvement plans? And making sure that if we need to invest more time in staff wellbeing, we can do that.
Okay for me to go ahead and come in. So I am interested, Sarah. I have another question, but I'm interested in your staff survey rate. That it was only 13.3% last year. That, of course, an average for Wales of 26%. So hearing that you're doing some targeted work in this area, hearing that you've had a people plan that you've taken all of this learning into, how is that translating for you in terms of assurance around your staff survey? Because listening to 13.3% of your staff isn't very much, actually. So I just wanted to get underneath the culture point that the Cabinet Secretary asked, because I don't know how you can group that as such a small response rate. And then there are big areas that are coming up and which consistently call out culture in your mental health service and in other services that we've seen. So I just wondered, what are you doing about that?
So I think having a return rate of 13% was not acceptable to us, and we were very disappointed, and took stock and consideration to understand how we got to that place. We did at the time of that survey have an internal employee experience survey, which we ran twice a year, and that had a much better return rate than cumulatively. So we made a decision to stop that internal survey and to drive everything through our NHS Wales annual survey. Really, because that will support us to measure our baseline and a broader range of questions, and also attract a broader audience as well. We had a very detailed action plan in place this year and communication strategy supported by all of the board. And we're really pleased that we've been able to achieve a return rate of 32.1% this year. Set an ambition of 26%. We are absolutely thrilled to be able to achieve that. And just for assurance, that hasn't been evidence that we've used to refresh our values and behaviours framework or to write our people plan. There was bespoke and specific engagement, over 7,000 points of contact, 3,000 people responded to surveys, and over 225 engagement events with groups of staff and groups of leaders to design our values and behaviours framework and our people plan. So listening to staff in various ways, and some of the ways that Nicola has described, is of the utmost importance to us.
Sarah, happy to acknowledge that work and change. Thank you very much. So my question then, leading on from the Cabinet Secretary's question around how you learned, I understand, and I'm cited to some similar concerns that have been raised around leadership, culture, safety concerns in the neonatal unit that I know I've been in discussion with you all over. This is the neonatal unit at the Grange I'm talking about. So I'm wondering what assessment the board has made of these concerns, what actions the board has taken to demonstrate that these concerns are heard, they're taken seriously, and that you're acting on.
So I'll hand to Jenny in a second. Obviously, Jenny led a lot of the quality improvement in mental health and is obviously very cited. So we are aware of the individual who's raising concerns. We've been in communication with the individual. We really welcome people to share their concerns, as we take them very seriously. And we've been using those to inform our improvement plan and do that triangulation around what people, patients, staff, and other stakeholders are saying, along with our outcome, our quality data, to make sure that we are cited on everything, and any of the concerns raised be validated. So we absolutely have taken those really seriously, and Jen can update in terms of the work we've done in terms of developing that improvement plan and informing the board, which we're very excited on our maternity and neonatal services, because in September we took our annual report to the board with kind of all of the improvements we've been making, that Jen, you can follow up.
So just a point I'd like to make on our learning from the mental health and learning disability example. But one of the things, as well as the culture, was around the safety and quality improvement systems. And I think, you know, we take deeply seriously the safety and quality of our staff and our patient experiences and our quality metrics. And, you know, we work tirelessly to make sure we reduce variation, to ensure that we are reducing harm and improving the quality of people's experience. By people, I mean staff and patients. And we did a lot of reflection as part of our learning from our experience in mental health and learning disabilities. And we have built that into the quality management system that we launched in March. So we've already embedded a quality management system that triangulates and utilises data to highlight areas of concern and to enable us to look proactively. But also we've triangulated that with experience data from a staff and patient perspective to make sure that we're able to look at those quality metrics in the round and make sure that any change is meaningful. So, you know, in the maternity and neonatal perspective, you know, those are key priority areas of focus for us as a health board. You know, it's where we've taken the learning from our improvement approach to mental health staff engagement with that. It was critically important, and that's what we've done when we've looked at neonatal services. So again, coming back to that triangulation, part of my job as the Executive Director of Nursing is to triangulate that evidence, to look at what the outcome data tells us, to look at what our staff and patient and public data.
What is it?
So it's telling us that we have some areas to improve. We've got good quality outcomes for our neonatal services. We've got good service user experience. And we've done a piece of work with Sarah jointly, looking at listening to staff within the unit. We're early days of publishing that report, but we've had some high level feedback, and that's completed. But we know there are a number of things that we needed to do. So in the similar vein to the two we did with mental health and learning disabilities, we've triangulated the data, we've looked at the quality and outcome data, and we know there's areas to strengthen, and I think it's important that we use that word strengthen. We have fully appraised and briefed the board. I've worked with CIMA and CIMA's predecessor to make sure that we have robust oversight mechanisms and governance mechanisms in place, and that the board are fully cited on the improvement plan and the progress. So we've looked to what we need to do. We're working closely with the clinical leadership team to strengthen their engagement in the improvement actions. We've focused on listening to staff, looking at the staffing and skill mix to ensure that aligns with best practice. We've worked to strengthen the clinical oversight and leadership at that really frontline level, making sure that there's leadership visibility, and that's supporting wellbeing and supporting our quality improvement. And I think the quality improvement element is really important, because that's the way in which we'll get staff supporting and working with us. And we know there are always opportunities to strengthen patient safety culture. We have a targeted programme of work to do that. We know there is all further work to be done, but we also take that seriously from a broader health board perspective.
So we hear exactly how seriously the board takes safety and quality, and I would expect you to do so. The question I guess I want to ask the board is, are you assured that your neonatal unit today is safe? And from the assessment you've made, the triangulation of data, the listening to your staff, the hearing the concerns. Is the board
and I
assured?
think, you know, from our perspective, so we use our own local data. We use Embrace, which is the national data that gives you your kind of your outlier status and your metrics. We use the National Neonatal Audit Programme, which brings us a lot of them out. The 2024 report has just been published. We, as an executive team, weekly monitor any NRIs, SIs that come up through that. I think we've had about 500 plus babies through the unit this year. We've had 4 complaints. We have really positive patient feedback. We measure, you know, the really sad cases, unfortunately, don't make it, but they are in line with previous trends. There's nothing that is suggesting there's an outlier. So as a board, we've shared all of that data in terms of the public information available, and are assured that there is not an outcome quality data that is, notwithstanding that we always know there's things that we can improve on, which is what we focus on.
The quality and outcome data wouldn't indicate that they're, that the service is unsafe. We've also triangulated that with the network as well, and obviously with the Joint Commissioning Committee who commission the high intensity,
It's valid.
I was going to move to another challenge area, so maybe.
Not on this, it's a wider bit about.
Okay.
Okay, so another area where there have been challenges is around primary care and the management of some GP contracts in recent years, where there have been issues with the management and quality of some GP services operating via contractors. So I suppose what I'd like to know is how confident are you in your current primary care delivery model? What lessons have been learned from those from that situation, from that incident, and how are you bringing in leadership from primary care into ensuring that primary care services are robust, sustainable, and of high quality, particularly in the context of your place-based approach that you've been describing?
And you've been doing some lessons learned specifically already, Harley, haven't you? So if you could respond to that as part of that.
Yeah, so if I just pick up that specific, because that's been our main challenge over the last 12 months. We've had a very challenging time with the particular partnership who had 8 of our practices previously appointed, because we were managing some of these locally as a health board. And there was a very clear rationale and ambition that this would help us provide more sustainable primary care in some of those areas based on the model that was shared through the process. Obviously, we about 6 months in, there was some concerns being raised, and once they escalated to a level, the health board responded really quickly. We put the partnership into enhanced monitoring for all the practices, albeit they were 1 or 2 practices that were having more problems than others. We responded really quickly as a board. I personally, as well as the chair and others, took this situation really seriously and listened to the kind of public and staff concerns that were emerging as a result of these issues. We also, so the enhanced monitoring was put in place, which was fortnightly meetings with this partnership. We also did patient safety visits, and we monitored the kind of access metrics, recognising the contract hasn't got any specific hard performance management. So we were making sure that they weren't in breach of contract in terms of the way the current contract is kind of presented. So there wasn't anything on the breach side that we know there were some issues around sustainability we're facing. We also asked internal audit to kind of do an audit around our appointment into the practice, any lessons we've learned. Did we follow the vacant practice process, and were there things that we could learn more widely for Wales as well in terms of what had emerged on this particular contract. Audit Wales have also commissioned a review, which I think was welcomed, and I know we are waiting the report. I think some of the lessons learned which apply for the contract process is how we strengthen pre-contract award and some of the due diligence right up front, possibly enhance monitoring new partnerships for the first 12 months anyway. So even though we were in the process of a transition, something much more robust. I think we've talked at the national level and contract, part of the contract review, does there need to be slightly enhanced contractual levers in there to manage some of these similar situations before, and how we share that learning across Wales. So we took it very seriously. We've now got 3 partnerships that are still with 3 practices that are still with this partnership that are still in enhanced monitoring, and we are working really closely with the partners in terms of ensuring they've got sustainable plans for the future.
And I think we also have to look more widely. In some parts of Wales, it's extremely difficult to fill these contracts, and yet we have a great opportunity to put all the community resource on the table and design a service that meets the population.
I'm sure it's to come in on that.
Yes, I think that's very helpful in terms of the contract and the specific situation. Yeah. But are there any wider lessons about how do we ensure that we've got robust, resilient, sustainable, high quality primary care services for our communities, and how confident are you that either you have them or you have the plans to ensure that?
Yeah, so I'll see if Tracy wants to come in on anything, but I think we've got quite a strong, well-established cluster set up in Went, called the neighbourhood care networks. They are quite mature, and work really well in terms of trying to make sure we've got integrated primary community services, and the plan we've got around place-based care is to strengthen that. I think we have got challenges around some practices. I know there's a deepened practice kind of consortium of those, you know, and we are, as a health board, managing, and I think of the 5 that we took back over, one of them has been awarded to a local GP, but 4 of those are still in our management, and we struggle to make those sustainable, and that is a worry for me. I think we've got to try to look at doing something different for some of these practices and they're usually in areas where we've got high deprivation and they're the population that needs primary care more than anyone. So that's why the place-based care focus is really key, and we are looking at working with other GPs in the areas to see how we can make some of these practices more sustainable in the future. So I don't know, Tracy, you want to add on the place-based care work and the work we do with primary care needs?
Yeah, no, it is a really active space, and I think Nick said a lot of it in terms of how do we challenge the variation, and get that sustainability, and really make sure that we've got really robust primary care where we can make the biggest impact, where we are seeing high levels of deprivation. We're still in the early stages of place-based care, and obviously the work that you do in CMO around communities by design is really going to help give us a clearer framework on that. But the engagement we've had and some of the opportunities we have to do that, not only with primary care, but also how we're working across an integration basis with our local authorities as well, building on the community assets and feeding in that. And that is a really good relationship that's forming across the NCNs and that community platform, because there is also a need that's recognised from the local authority and through a social care housing point that we need that primary care lens to inform that and vice versa. So that model is giving us the opportunity to explore this in a different way.
Okay, thank you, Jacqueline.
So, just trying to sweep some of this up a little bit, so that we've talked a lot about what has happened, and it's sort of been more retrospective. So there's a question for me about how does the board, and can the board begin more prospective in terms of how do we identify when something is going wrong before it hits the buffers? Have you found a way of how you're beginning to take that look forward that actually identifies areas that might be going wrong before they've gone wrong?
So
the quality perspective.
Well, quality, but it could be more than, it could be,
I describe, I mean, that's obviously central to our quality management system and the 4 domains of quality. So whilst the national system is developing, we've obviously taken those domains and implemented them. So we've got a very robust system and process that we've developed in a quality outcomes framework, which starts to bring together data and experience in a way that enables us to identify services that are struggling. What we've done as well to build on that is we've implemented a system of ward and team accreditation. So we're growing that bottom-up approach to teams understanding their data, understanding themselves when there are concerns, and how that then is escalated through our governance structures. We've established a quality management group that holds the quality metrics for our operational divisions, and we get a feed up from the front line around any areas that are struggling, any learning, importantly, and how we work to support them.
So I think the bit for me is that there are things that will happen in your workforce space, and other things that happen in your finance space that actually also then contributes. So it's more, for me, that's what I was saying, it's more than just the quality bit, it's actually about your people and what else goes on. So
just a little to add to that, because it's really,
even though you've got a few more minutes.
yes, we've got kind of we meet twice a year with our divisions as an executive team. Obviously, there's a monthly process. So we've now got a new strength and performance management framework, which looks at performance, finance, workforce, and quality, and obviously leadership culture. And we've kind of got a bit like you've got health boards and escalation. So where we can see issues of concern going through, or that triangulation is raising, that's where the mental health issues came up. We actually picked those up early and those into a level of escalation. But we've strengthened that with things such as leadership and culture, which is a new domain we've introduced this year. So I think that's a helpful mechanism.
Thank you. Well, we're about to reach the end of the agenda, so just conscious for those people watching that necessarily the focus in this discussion is on things which we want more assurance and things which we're finding challenging. So there's been less opportunity to talk about the successes which Health Board has. I just want to acknowledge that. But if there's anything in a couple of minutes, Anne, that you feel hasn't been, you haven't been able to say, which you want to put on our radar, make sure that we understand or know. There's a couple of minutes for you to do that now, if you like.
I think as a board, we're very proud of the services that we deliver to people, and we're ambitious to make them even better, cost effective but better, and we will continue to do that. And one of the things about the board, I think it's got the same moral values, and we all want a better future for the population. And I liked, particularly in this organisation, the fact that if you ask the staff what's wrong, they will tell you, no problem about that. But they also will come up with what they think might actually improve them from their point of view, which is really, really helpful to design a good quality system that's sustainable for the future. So I'm very grateful for the time that you've given us today. I do hope we've answered your questions. Thank you for that. Thank you to my colleagues.
Thank you, and to you and colleagues on the board as well. The three key points for me coming out of the discussion today, and it's been a very wide-ranging discussion, is firstly on the financing on the budget.
Yeah.
Absolute need to get a grip on the deficit and to drive that down. Really need to see that quickly. Secondly, in relation to the Grange, a real focus on that. We cannot be in a position where we have our ambulances queuing outside over winter months. There has been a period of success in getting those numbers down. As you've acknowledged yourself, that slipped back. We absolutely need to see that heading back in the right direction quickly. And then thirdly, in relation to planned care, making sure that you're drawing on all the latest expert advice, delivering on that clear to utilisation and the other mandatory actions in this year's planning framework, so that we can make sure that, as well as the funding coming into the system, there are efficiency and other changes which we know deliver both for patients but also for your financial position as well. Thank you very much for your time for the discussion today.
Thank you very much.